Assalamu alaikum everyone. Today's video is a continuation of my previous lecture on stable angina pectoris. In this video, we will discuss the management of angina. But before starting the management, I would like to discuss the few words about Canadian Cardiovascular Society angina score, syndrome X, variant or Prinzmetal angina. So let's start with the Canadian Cardiovascular Society angina score. These scores are important to check the prognosis of angina patients, and it is classified into four classes. In class 1, the symptoms of the angina develops during the strenuous or prolonged physical activity, and there is no limitation on ordinary daily life activities. In class 2, the angina features develop during the vigorous physical activity, and there is a slight limitation of ordinary daily life activities. In class 3, the symptoms of angina are present on everyday activity, and there is a marked or severe limitation of the daily life activities. And in class 4, angina occurs even at the resting state, and there is a total limitation of daily life activities. Now a few words about the syndrome X. It is nothing but the typical angina or angina on the exertion. Let's talk about its pathogenesis. The deeper myocardium is supplied by the small blood vessels or the small branches of the coronary arteries, and these blood vessels or these small coronary arteries are less dilated, which are present or supplying the deeper myocardium. As a result, on the coronary angiography there are no findings on the coronary, because the doctor mainly focus in the angiography on the large coronary arteries, not on the small arteries. That's why the coronary angiography shows no findings. But the stress exercise test is positive in these patients. There is a stress, that is ischemic changes, can be seen in the ECG paper. If that's why the stress test is positive in these patients. It syndrome X patient has excellent prognosis, and it occurs usually in the female, and it basically good response to the nitroglycerins or nitrates occurs in these patients. Now come to the variant or Prinzmetal's angina. Basically, it is due to not due to the atheromas, but it is always in most of the cases it is due to vasospasticity or vasoconstriction. In only few cases, atheromas, fixed erythromatous plaques are present. In only few cases, not in all the cases. In mainly it is due to vasospasm, and it is more common in the females who are smokers, and angina occurs at the resting stage. Look at the ECG, that there is a ST segment elevation in variants or Prinzmetal's angina, because when there is a vasospasm, there is a transmural ischemia occurs as a result of this vasospasm. There is transmural, that is whole layers of myocardium becomes ischemic, and the electrical activity is moving towards the positive electrode. That's why there is ST segment elevation. In the management, calcium channel blockers like amlodipine, nifedipine, also will verapamil and deltaazine shows a good response, as well as nitrates, because these drugs causes the vasodilation and relieves the spasm of the coronary arteries and relieves the symptoms of angina. Now come to the main topic, that is management of stable angina pectoris. The main step is lifestyle modifications, that is cessation of smoking, which decreases the risk by 50% in just 1 year of quitting the smoking, and reduction of weight, exercise regularly, diet contain the fruits and vegetables and low fatty diet, control the blood pressure, control the sugar levels, and treat the hyperlipidemia, because hyperlipidemia is dangerous and causes mainly the coronary artery diseases. So treat the hyperlipidemia, decreases the cholesterol intake. Also sometimes use the statin drugs, that is HMG CoA reductase inhibitors. These drugs basically inhibits the synthesis of cholesterol. These includes atorvastatin and simvastatin, etc. The other therapies are antiplatelet drugs. These basically drugs decreases the mortality and morbidity in these patients, and inhibits the aggregation of platelets in these in the coronary arteries. That is, in short, we can say that it inhibits the thrombus formation. These drugs includes aspirin. It is very common drug and used in almost all the patients with the coronary artery diseases. The daily dose is 75 mg. It reduces the mortality and morbidity in these patients and inhibits the cyclooxygenase pathway. The next drug, if the patient cannot tolerate this aspirin, then clopidogrel is the second choice in place of the aspirin. It is basically indirect inhibitor of glycoprotein 2b3a, and ultimately inhibits the platelet aggregation and hence inhibits the thrombus formation in these patients. So now the main drugs are anti-anginal drugs. These includes the nitrates or nitroglycerins. Basically, these drugs are vasodilator. By venodilation decreases the preload, and by arterial dilation decreases the afterload. As a result, the workload on the heart decreases and the oxygen demand of the myocardium is reduced. But there are some side effects and relieves the symptoms of angina because of the decreased preload and decreased afterload on the heart. There are some side effects of these nitrates. These include syncope, headache, and orthostatic hypertension. These are available in various forms like transplant, some skin patches like IV forms, and also oral drugs are also available. Now the next anti-anginal drugs are beta blockers. These beta blockers are also very important in the management of stable angina pectoris. These includes non-selective beta blockers like propranolol. Propranolol is contraindicated in asthmatic patients because it causes vasospasm, while the other selective beta blockers include carvedilol and bisoprolol, metoprolol. These are commonly used nowadays and does not causes the bronchospasm. Basically, beta blockers inhibits or decreases the contractility of myocardium, also reduces the heart rate. As a result, decreases the oxygen demand of the myocardium and relieves the angina symptoms by decreasing the oxygen demand. Now come to the next drugs. If the patient cannot tolerate the beta blockers, sometimes doctor prescribes the calcium channel blockers. These may be dihydropyridine calcium channel blockers like nifedipine and nicardipine, and non-dihydropyridine calcium channel blockers, which includes verapamil and diltiazem. And some side effects are myocardial depression, constipation, edema, and flushing. So these are the some side effects, and the mechanism is almost same as some calcium channel blockers reduces the heart activity, and while the others reduces or relaxes the smooth muscles of the blood vessels and causes vasodilation. So these are also useful for the angina patients. The other drugs are nicorandil. This is basically a potassium channel activators, and it basically relieves the symptoms by vasodilation. And the other rarely used drugs are ivabradine. This is funny channel blocker on the SC node and decreases the heart rate, so decreases the oxygen demand of the myocardium. Now come techniques, which includes percutaneous coronary artery interventions and coronary artery bypass grafting. Let's talk about the percutaneous coronary artery intervention first. Through the skin, insert the catheter through the femoral artery. At the tip of catheter, there is a balloon which is used to open the stenotic point in the coronary artery. Then put a metallic stent to prevent the restenosis. The stents are basically medicated and having thrombolytic agents. So this process is also called angioplasty with balloon and stenting. Indications are these are more commonly used for acute coronary syndrome. We will discuss the acute coronary syndrome in the next video. And its indications are they are used in acute coronary syndrome with ST segment elevation and should be considered in a single or two vessels coronary artery diseases. In the stable angina, it provides a symptomatic relief, but it is unclear that it improves the survival or not. But the important complication of percutaneous intervention is that it after sometimes that restenosis of the dilated vessels occurs. Now, few words about the coronary artery bypass grafting. A new channel around the obstruction, and blood goes directly and bypass directly into the myocardium and bypass the coronary artery. Graft is basically placed in place of this in place of this obstructed coronary artery. So the graft can be any artery or it can be a vein. Grafts can be arterial like internal mammary artery, radial artery, and venous like saphenous veins. Basically, the indications are for using this CABG technique are if three vessels are diseased with more than 70% stenosis, or the left main coronary artery is stenosed with more than 50% obstruction, or two vessel disease in a patient with diabetes, or there is a left ventricular dysfunction. So these are the various indications for using this CABG. The complications are stroke and cognitive decline. So these are the two techniques which are used basically for the revascularization, but more common technique and more important technique which is used nowadays is CABG, that is coronary artery bypass grafting. So this was whole about the management of stable angina pectoris. Thank you so much for watching this video.